legacy lecture this past year at the Michigan ACC, and it was so good that we wanted to invite him again. We had so many great comments, and I wanted to hear it myself again. So I think you're in for a treat. For those of you that don't know, Dr. Bates, he's a professor of medicine and cardiology at the University of Michigan. Really has been a pioneer in the treatment of acute myocardial infarction and acute coronary syndrome. He did his graduate work at Princeton, and then went on to University of Michigan Medical School, and has really stayed there since then. Since then, he's been a member of multiple editorial boards and medical journals. Really written the guidelines really in terms of percutaneous coronary intervention on multiple writing committees. Has been part of the ACC Board of Governors and Board of Trustees, as well as part of the AHA scientific sessions. So truly honored to have him as part of the Michigan community, and to give us this lecture about really the history of how Michigan has played such a huge role in developing the therapy for myocardial infarction. So Dr. Bates, I'll lead it off to you.
Well, thank you, and thanks for tuning in here. About a year and a half ago, I did give this lecture. It is called a legacy lecture, so that means I'm getting old and looking backwards instead of giving you a late-breaking clinical trial that's going to change future practice. I see Barry Lewis and Farid Kaja are on the line here, so they'll appreciate some of this. I hope you younger people get some benefit out of it, because this is going to mostly be a historical review in the past, maybe a couple slides about me, but mostly about the really important role cardiologists in the state of Michigan have played in this field. I went into cardiology because of acute myocardial infarction. During our fellowship, my fellowship, we did our first PCI and then our first lytic treatment. So I've lived the whole spectrum of this reperfusion therapy story, as has Farid. I'll do a couple of sidebars here. Think of your grandfather going off on tangents, but there's some good stories to tell. I don't want to show you a bunch of graphs. So let's start with a case history. Eisenhower was a World War II hero. He was president of the United States when I was in my early years. He liked golf. If you look at his hand in this picture on the left, you can see he's smoking one of the 4 packs of cigarettes he smoked. If I can use a stereotype, he had an Irish temper. I don't know his cholesterol. I don't know his blood pressure. But he was playing 27 holes of golf as president of the United States out in Colorado and not feeling well, blaming it on the Bermuda onions he had for his lunch, another male stereotype where they think it's anything but their heart. It was bad enough he skipped his cocktail, which was normal practice in the 50s, went to bed early. Then he woke up at 2 o'clock with severe chest pain, and Mamie, his wife, calls Dr. Snyder, who's his family physician, to come over. This quotation is from a book on his heart attack. The president was lying in a room in a house in Denver in the middle of the night with a heart attack. So that means no security. He's not in a fancy hotel. He's visiting somebody's house, if you can imagine. Only one person in the world, his physician, Howard Snyder, knew it, as he informed neither the president nor Mrs. Eisenhower of his tentative diagnosis. No oxygen supply was available. He did not summon an ambulance. He was not a cardiologist. No second opinion was sought. No consultation arranged. And he waited till the next morning. And they called up some doctors at Fitzsimmons Army Medical Center who finally brought an EKG machine over to the home at around 1 o'clock. And you can see the EKG changes, which are quite dramatic. He's got ST elevation in leads 1 and AVL. A lot of ST elevation in V2, 3, 4, 5, and 6. And this is probably 12 hours into his infarct. He's also got some ST depression in 3 and AVF. So probably this was a transmural infarct in his proximal LAD. We don't know. They didn't do they didn't have coronary angiography in those days, as I'll show you. But interestingly enough, the diagnosis was coronary thrombosis. a topic I'm going to touch on several times because it took another 30 years to prove that and have it accepted as the etiology of myocardial infarction. So what do? They call an ambulance. And here's a 1955 ambulance. There's no EMS. There's no life-saving equipment on the ambulance. They load him into this vehicle with 4 tires and they take him to the hospital. And it was Fitzsimmons Army Base, which is still there. He went into room 8002, which has remained untouched. My colleague Brahmaji Nalamathu visited a couple years ago, and they've kept it as a historical site. Treatment in 1955 was morphine for pain. He got papaverine and amyl nitrate for vascular dilation. Because they thought it was a coronary thrombosis, I guess, they treated him with heparin and warfarin, and they put an oxygen tent on him. You'll notice that none of this has anything to do, except maybe heparin, with the current treatment of STEMI. And they call that perhaps the first coronary care unit, which may be true because we didn't have coronary care units in this country until 1962. 1960 was a huge year. CPR technique was published. Clinical defibrillation was published. Desmond Julian said, well, we've got the ability to defibrillate patients and monitor the rhythms. Let's put all the infarct patients in one room and deputize the nurses to defibrillate patients who had malignant arrhythmias. And the mortality for MI immediately went down from about 35% to 15 or 20%. First CCU in the US was in Kansas City by Hughes Day. The University of Michigan, we opened ours up in 1963. And it's the single biggest change in treatment for myocardial infarction, the ability to defibrillate somebody who is basically dead and bring them back to life. So they brought in all the bigwigs, and these are his physicians. You'll see his personal physician is got a cigarette in his hand, like Eisenhower. This is Paul Dudley White, who was the preeminent cardiologist in the country from Mass General. And he had a press conference that publicized what a myocardial infarction was, and he became famous for preaching primary prevention. He helped start up the American Cardiology meetings and was a world famous cardiologist in primary prevention, exercise, rode his bike to work. And he told the public about what happened to Eisenhower, just like we heard about colon cancer when Reagan was afflicted. This was their concept of cardiac rehab. He had his infarct in September 23. He didn't see anybody in his cabinet for over 2 weeks. After a month, they let him get out of bed. After 6 weeks, they let him walk, and then he returned to Washington only to go to his farm for the rest of the year. So bed rest was basically the treatment, and the natural history with its complications were on that event timeline. So my first sidebar is that cardiovascular disease is not a stranger to the White House. You historians will remember that Woodrow Wilson was paralyzed in 1919, about 16 months before the end of his term, and his wife probably was the acting president of the United States, and he died a few years later. Warren Harding took over for him, but in his third year, he had a cardiac arrest in a hotel in San Francisco and died at the age of 57. Calvin Coolidge took over for him, completed 6 or 7 years, and then 4 years after he left the White House, he died suddenly. FDR had malignant hypertension, died in 1945 in the office from a stroke. Eisenhower not only had this big anterior infarct in 65, he also had a stroke in 57 that gave him some speaking problems. Had another MI in 65, was in the hospital in 68 with cardiac arrest and got defibrillated several times and lived until the age of 78 and died in 1969, 14 years after a transmural anterior wall infarction. So he really beat the odds because that's almost unprecedented for what must have been an ischemic cardiomyopathy. so he did well. Curiously, Lyndon Johnson had an inferior wall infarct the same year as Eisenhower's anterior wall infarct. His hypotension was so bad they thought he might die. He was in charge of Congress at that time as the Speaker of the House. So he must have had RV infarction with his inferior wall. He gave up his 3-pack a day cigarette smoking, was a pretty good citizen while he was president, and then relapsed when he got out, had an anterior wall infarction in 72, and then died in 73 at the age of 64. More recently, Clinton had bypass graft surgery at the age of 58, subsequently acquired a stent. And there was some controversy several years ago when George Bush was doing an executive physical and flunked his treadmill test and was found to have a 90% proximal LAD that they stented, even though he was asymptomatic. He was only 67. So note the ages here. They're all in the late 50s, the early 60s. Only Eisenhower lived into his 70s. So this really was a malignant disease in the 1950s and the 1960s, which makes the treatment advances so spectacular and rewarding. So let's go back and talk a little bit about how this all began. And I'm going to start with George Dock, who was the first full-time professor of medicine in the U.S., trained at Hopkins by Osler, who said he knew more about clinical procedures than anyone in the United States, had a great reputation for teaching in the amphitheater with all the students looking down from their perches. He was our first chair of internal medicine from 1891 to 1908. He was also a great clinical pathologist. And he published this article, a copy of which I have in my files, in 1896, that is an exquisite description of the pathology of atherosclerosis with fibrosis, lipid pool, plaque rupture, thrombus formation, and postulated that it was the cause of myocardial infarction. You notice in this reprint, they even misspelled his name. That's how primitive thing was back there. We had a professor named Davenport, who's our institutional historian, and he got so upset he wrote the correct editing of the guy's name in the article. But to read it is spectacular. And then it still took another 80 years for everybody to agree that it was a coronary thrombosis, as was suggested in the Eisenhower years. And James Herrick is another important person. He gets credit for the first description of clinical myocardial infarction, first clinical description. He probably was not the first one to observe it. Dock was not the first one to postulate that coronary thrombosis was the issue, but there weren't any great meetings, or there wasn't a sharing of literature to figure out who was really first to describe it. He interestingly received his undergraduate degree from the University of Michigan, which is one reason why I put him up here. Then he went to Chicago and had a very impressive career, and is widely quoted in this classic 1912 article from JAMA on describing the clinical features of acute myocardial infarction. So that's thrombus, maybe. That's clinical presentation, maybe, but you need an EKG to make a quick diagnosis. A guy named Eindhoven from the Netherlands got the Nobel Prize for inventing leads 1, 2, and 3. His recording machine is on the left. You see the subject has 3 limbs and salt water. The cord going up to the right corner might be the first example of telemedicine, because they had to take the signal they generated and transmit it a mile to the recording station. It took 5 people to run this machine. And now you can get an EKG on your wrist or on your cell phone. So the technological advance has been important in this field, as it is in every field we have. But as Frank Wilson, I want to emphasize, who is our most preeminent cardiologist probably in the history of cardiology in the state of Michigan and at the University of Michigan. He was born in Livonia, got his undergraduate and graduate degrees from Michigan, and was our first official chair of cardiovascular medicine or cardiology, getting the appointment in 1920. He was given the opportunity to use the Eindhoven galvanometer, the 3-lead EKG machine that Walter Albion Hewlett purchased from Europe and had shipped over on a boat and they installed it under a closet, and Wilson was tasked with trying to figure out how to work it. Then he went off to Europe, was fortunate enough to be in the same hospital as Sir Thomas Lewis, who with Einthoven, these guys were the three founders of electrocardiography. Sir Thomas Lewis was interested in rhythms, basically, and P-wave and QRS morphology. And it was ornithologist like Wilson, so they really bonded. Wilson came back to St. Louis for a year or two, then came back to the University of Michigan and set up the cardiology program. And he's famous for teaching himself theoretical mathematics, figuring out something I don't understand and how to negate competing forces from different vectors when you measure the EKG and neutralizing them, and invented 9 of the 12 leads on the electrocardiogram, an enormous contribution. So 1, 2, 3 is Einthoven, AVR, AVL, AVF, V1 through V6 is Wilson. His next in command was Franklin Johnston, who was our second chief of cardiology from 52 to 68, when he had a severe anterior wall infarct and died. And there's a long story about Johnston that's quite interesting. But his father was a professor of electrical engineering at the university, and Johnston was an electrical engineer. And the V stands for vector. So Wilson imagined and created those 9 EKG leads, and Johnston labeled them as vector V leads. So I'm fond of ruminating as an old man, telling everybody I can who comes through Michigan that every time they see an EKG, the rest of their life, to remember where they trained, because the EKG, 75% of it came from Michigan. And I'm going to go a little bit off on tangents, because you have to have a right heart catheter to get to a left heart catheter. This is a great story about a crazy German who was an intern and frustrated about giving intravenous drugs for people during cardiac resuscitation, whatever that was, in the 1920s. And he actually gets credit for doing the first cardiac catheterization in a very curious way. He proposed to pass a tube into the heart. It was rejected by his superior, so he paid no attention to that. He romanced surgical nurse Greta Ditzen and convinced her that she was going to be the first person to have a right heart catheterization. She unlocked the cabinet. He laid her down on the x-ray table. He strapped her down. And then he did the antecubital cut down on himself and advanced the urethral catheter up into his chest, walked down for a chest x-ray, and then published it, which is important because you don't get credit unless you publish it. So there's certainly a sexual harassment. He tried before on a friend, and he got stuck in the shoulder and they quit. I think he tried himself once before. So what happens? He got fired that afternoon. He didn't get any cardiology posts. He became a urologist and then kind of a country doctor. He knocked around, had problems with depression. In 1956, he got a telephone call from Norway and was awarded the Nobel Prize in physiology or medicine, shared with Pornan and Richards in New York City, who were then developing tools to record heart pressures and describing different hemodynamic profiles, which is what we do without thinking now in the cath lab and in the coronary care unit. But that, for those of you who complain about doing right heart caths in the cath lab, that is the only clinical cardiology event that's been awarded a Nobel Prize. So I know everybody wants to put in stent in people, but it's the right heart cath that started everything and was rewarded. Go back to Detroit and left heart catheterization. To do primary PCI, you have to image the coronary arteries. Mason Sones, who Fareed can probably tell stories about, was a resident at Henry Ford. He was a pediatric cardiologist, went to Cleveland Clinic, and serendipitously did the first coronary angiogram in 1958. But back then, instead of putting it on social media an hour later, he did 50 patients, thought through it carefully, and presented it at the American Heart Meeting, which is where the only place was you could share clinical research, because there was no internet, and the journals were only a couple. And this was pretty cool new technology that he immediately recognized would change the game. So it wasn't forethought, it was he recognized an accident and took advantage of it. So James Forrester, who was famous for helping develop the Swan-Ganz catheter, and is a great speaker and has written a book on his journey through cardiology, calls this guy one of the most unforgettable characters anybody could meet. He didn't care how he looked. He cursed like a sailor, which would get you fired nowadays in the politically correct halls of the University of Michigan. He liked to shock people. And he was such an addict with smoking that he would keep a sterile forceps on a table next to where he was doing his anacubial cut down to do his arteriotomy, to push the catheter in, to close the arteriotomy, close the skin, as we did when I was a fellow, the Soane's technique. And he would take a couple puffs while he was doing this. So the patient, the index case was a 26-year-old patient with rheumatic heart disease. Back then, you had a multi-purpose catheter you put in the left ventricle and you pulled it back and did an aortogram for those two contrast images. And just as he pushed the injection button on the power injector, the multi-purpose catheter flipped in the right coronary, which for those of us who use multi-purpose catheters is not completely surprising. We've all had that experience. So people thought the patient would die if you put a right heart catheter through the right heart and that proved not to be true. People thought that contrast down the coronary arteries would stop the heart, and it did, as we used to see in the old days with ionic contrast. We'd have to cough them out of it or sometimes pump on their chest a couple times. You don't see any of that anymore with the new contrast agents. But fortunately, this person's heart started up again, and there was the first coronary angiogram. And that allows you to eventually think about revascularization. So this is what the cath lab looked like at the Cleveland Clinic in 1958. The patient's on the top on a table. The radiologist is sitting in this bay underneath it. In his hand is the power injector. The arrow in the right lower corner is the 35 millimeter cine film that Fareed and Barry and I grew up with. And on the left here, you see the first coronary angiogram, October 30, 1958. There's Soane's in the middle on the right with Rene Favellaro, who again in history is credited as being the first to popularize coronary bypass graft surgery, but again was not the first to do a bypass. Ms. Herrick was not the first to see myocardial infarction. But that led the way to the first coronary angiogram, first coronary bypass, which the angiogram of which is shown here. Took 9 years to get there. Think about that for the progression of technology. So that's right heart cath, that's coronary angiography. Let's talk just a minute about angioplasty before we get into reperfusion. This is Andreas Grunzig, who had the idea of using a balloon to dilate a coronary stenosis. It had been done with wires before, as I'll show you. This is his poster at the 1976 AHA meeting that attracted very little attention. He came back a year later with 4 cine films of a balloon angioplasty on patients, and it was standing room only. But it took a little while for him to get there. This was his research lab, his kitchen table. He had to figure out plastic. He had to figure out how to inflate and deflate a balloon and how to attach it to the catheter. A little bit of wine helped. His first wife is on the left in the lower corner. His invaluable research assistant, Maria Schlumpf, is there next to him. The first idea was the catheter picture in the right corner. But when Fareed and I started doing angioplasty, we had this DG 2030 balloon that was pretty slick by their standards, but I think it had an 8 French shaft. The 2 markers were to help position the balloon, but there was no movable wire until a couple years later when John Simpson invented it. There was just a small, less than a centimeter long wire attached to the tip where you can bend it and move through the coronaries, but it was tricky. So it took Grunzig a long time to find the right patient because it had to be a straight shot. This is a 38-year-old man who had progressive unstable angina and agreed to do it. Grunzig did it on September 16, 1977. This guy was still alive for the 40th anniversary, and I hope he's alive in a year and a half when we celebrate the 50th anniversary. he's had a couple stints in the decades since then, but has had a long life into his 80s. And fortunately, there was no restenosis, and it worked. Myler and Sturzer were two people that immediately saw the potential benefit of angioplasty after seeing the poster at the American Heart Association, and they did the first PCI procedures in the U.S. on March 1st, 1978. Myler was a groin operator. Sturzer was the old Sones technique on the other side of the country, and they were great friends. And this is what it was like to party in the old days. It was quite a small club, and everybody had a great time, excited by everything that was happening. And there's another little sidebar. The cool thing about this catheter that we got in 1980, when I was a second-year fellow, was you could measure the distal pressure off the end hole, and you could measure the proximal pressure. And you guys are doing flow wires now, but we could do it with catheters. The only problem was there was an 8 French catheter across the stenosis. So you could see the proximal pressure and equalize them on the left hand of this panel. Then you could pass the balloon across, measure distal pressure, inflate the balloon a couple of times, and then measure whether you've relieved the stenosis by seeing how the pressure gradient improves. So pressure gradients are not new. And just as another little sidebar, when I started out, it was before the Apple computer. We had an interesting guy named Bob Vogel, who was my first chief, who had a research assistant who was learning about computers. He was able to code in a color situation where the frames on the first cardiac cycle were red, on the second cardiac cycle was yellow, then white, then green, then blue, which is basically the same thing that Mike Gibson did several years later in his Timmy frame count. If you gave a shot of contrast, which is a vasodilator injected 8 to 10 seconds later, you could see an improvement in hyperemic flow. And if you look at the top panels, baseline on the left, you can see the red goes farther down, and there's a bigger blush on that right coronary artery, and the same thing on the left coronary artery. You can see it goes from blue to white. So you could measure coronary flow reserve. We actually did it before and after angioplasty. We did in bypass grafts. We did in some other things and had maybe 6 or 8 publications. And we included Grunzig as an author on this. So I'm on a manuscript with Andreas Grunzig as senior author, which I'm proud of. But we're doing coronary flow reserve again 42 years later, which shows you how old I am. And again, makes the point that it's hard to discover something new. We just measure it in a different way. So let's start talking about reperfusion therapy. Let's go back to the thrombus. There's a very influential hematologist named Sal Sherry working in Philadelphia, who was investigating streptokinase and urokinase as lytic agents, and published a very important article in 1959 in patients with myocardial infarction that sparked probably 20 years worth of rare randomized trials of intravenous lytic therapy, some of which worked, but some of it didn't, because they would diagnose the patient 12 or 24 hours later. So the concept of fibrinolytic therapy at least begins with him, even though it took another 25 years to legitimize, again, showing how slow progress was in the old days. The person who retrospectively gets credit for the first intracoronary administration of fibrinolysis is a Russian named Chazov, who published a 2-patient case report in the Russian literature in 1976. One of the patients reperfused with IC streptokinase, one didn't. And then it got lost, as did his citation, for years until somebody rerouted it through the Western literature. The first person who really gets credit for the first PCI, the primary PCI, is a German named Peter Rentrop, who was at Detroit Receiving Hospital for his internship. I don't know if Fareed knew him at that time, but he went to Cleveland Clinic, learned coronary angiography under Sones, then went to New York and broke all the rules, like all the great investigators did, by doing acute angios on patients with myocardial infarction. Back then, you could only do patients with stable coronary disease. You didn't want to study somebody with acute coronary syndromes or operate on them. And he had a patient that occluded in front of him, and he passed a wire down and the artery recanalized. And that's this set of photos from 1978, July 12th. So this is the first primary PCI. You can see the mid-right coronary closed. He put a wire down, it reperfused. He then did a couple more patients where he tried nitroglycerin on the left, didn't work, gave intracoronary streptokinase on the right, and it did work in many patients, suggesting that coronary thrombosis and not vasospasm was an etiology for acute myocardial infarction and acute coronary occlusion. That's 1979 in a journal called Clinical Cardiology. So you've got these private practice guys doing these amazing discoveries. The popes of cardiology didn't buy any of it. They had their own theories. Bill Roberts, our iconic cardiac pathologist, was slicing up arteries and measuring atherosclerotic burden. He was convinced that burden predicted infarction. And I think he's right. That's been proven several times. So that's not the pathophysiology for MI. That's the substrate. Very distinguished man named Attilio Masserai. Masserai was the big cardiologist in Europe. He was convinced it was spasm. And then Eugene Brunwald, who is the Pope of cardiology in the US, was, after years of doing beta blockers, he considered it was a supply and demand problem. And he wrote the major cardiology textbook for a few decades. And from 1980, presently available information does not justify emergency coronary revascularization as treatment for acute myocardial infarction. So this was a long journey and a tough sell. The other person to acknowledge besides Grunzig, who made elective PCI possible, was Jeff Hartzler, who was another maverick. Started out at the Mayo Clinic, and there's some good stories about that. Felt constrained by administration, went down to Kansas City and started up that famous cardiac center. And he's the one that did the first balloon coronary angioplasty. That film is lost, so I've reproduced the Rentrope picture, but it was the same lesion. The guy had that picture on the left, went up to the floor, had chest pain, the EKG changed, brought him back to the cath lab. And Hartzler had done a couple angioplasties by that time, opened it up. He's also the man credited for multi-vessel and complex PCI. Superb educator, huge personality, really out on the edge, greatly advanced the field. And he on one side with aggressive PCI and Grunzig on the other side with very thoughtful, mark it down, measure it, be sure you're safe. Angioplasty had quite a conflict for a couple of years till they came back together, and that's another story I don't have time for. But reality TV is not a new thing. So this is the reperfusion timeline. The FDA did approve streptokinase in 1977 for pulmonary embolism, DVT, peripheral artery disease, and catheter thrombosis. A guy named Reimer and Jennings and Duke were closing off coronary arteries, and they demonstrated that myocardial infarction takes hours, not minutes, to occur, offering a time window to perhaps limit infarct size. And another private practice guy in Spokane, Marcus DeWood, was doing acute heart caths like Rentrope on the East Coast, only he'd send the patients off to emergency bypass graft surgery. I don't know how he got that through the IRB, if there was one. And then the surgeon was pulling thrombus out of the coronary artery, which was definitive proof of acute thrombosis that Bill Roberts wouldn't have. He thought it was a postmortem event, but he wasn't working on living patients. So as I mentioned, Chazoff did the first ICSK recanalization. Rentrope did the first wire recanalization. Hartzler did the first balloon primary PCI. IC-streptokinase was approved in 1982. And then in 1983, a 250 patient study from Washington, and a couple years later, a 500 patient study of, again, intracoronary. Both of these were intracoronary. Streptokinase showed lower infarct size, improved ejection fraction, and a trend toward improved mortality, suggesting that there was something really good happening here for the first time. But really put it over the goal line was the ISIS study of 17,000 people, a true one of the early big randomized trials, where you can see on the top the placebo mortality, and I think this is 30 days, was 13.2%. Aspirin worked. It's an antiplatelet agent. Streptokinase, not a very good lytic agent, worked. Dropped it down to 10.4%. When you put antiplatelet and lytic together, you had an 8% mortality. Absolute 5% reduction in mortality, extraordinary. So that's where reperfusion therapy was really legitimized in everybody's mind. So I started in the cath lab in 1981 after our fellowship for 2 years. Joe Walton was the chief. Bill O'Neill started in 82. Eric Topol came in 85. Steve Ellis came in 86. Betsy Nabel came in 87. You all know Bill's success story as a major developer of primary PCI and devices. Eric Topol's had a big role in lytic therapy and randomized trials. Steve Ellis, the quiet one, actually wrote the most circulation papers. He knew how to do spreadsheets and data collection from his Grunzig days at Emory, and did a lot of work on defining anatomy and procedural things. And Betsy Nabel was chief of cardiology at us for a while, then went to NHLBI as the director, and then ended up at Brigham as the CEO. So they all did great. Joe's dead, and I'm still at the University of Michigan giving a legacy lecture. But this is really an incredible academic unit with 5 of us under the age of 40, and that's how exciting life was in the first decade of my life. So there's a great guy whose picture I'm looking at on the side. You can turn it on. Farid Khaja, who did the second coronary PCI in the state, if I'm correct. He was chief of the cath lab in Henry Ford. Joe Walton's the chief of the cath lab at Michigan. Bert Pitt was our chief of cardiology. Sid Goldstein was the chief of cardiology at Ford. And they got together to do a small randomized trial of intracoronary lytic therapy where they showed increased flow, no improvement in mortality because time to treatment was 5 hours, I think. But a really important New England Journal article. The second article was by Jeff Anderson and team. He was a cardiologist for 2 years with us before he went back to Utah and did his research there on a number of things. Really a remarkable career. So Dr. Khaja was the second angioplasty and maybe the first randomized trial of reperfusion therapy in the state of Michigan. Beloved by all of us at Henry Ford and the University of Michigan, where he finished his career. Back then, they didn't have mentors. They didn't have they didn't have YouTube. You had to go to the Grunzig, to the founder, and learn how to do it. So this is a spring course at Emory. You can't see it, but I'm here. Bill O'Neill is next to me. We're trying to figure out how to do angioplasty. Here's Grunzig, if my arrow is showing. Here's J. Willis Hurst. Here's Spencer King. Here's Myler and Sturzer. There are a lot of young people getting started, several of these who had very impressive careers developing the technique, but you would go look at one, see one, come home and do it. And it was quite iterative and fraught with lots of complications because a lot of the things we had to discover, it wasn't handed to us and taught to us by people who knew what they were. So it was pretty brutal. There are a lot of people having vessel closure, cardiogenic shock, death on the cath lab table. It was pretty impressive because we didn't have stents. We didn't know about antiplatelet therapy. So we did a lot. Bill got right into it. We were invited by Circulation to give a review article on what we were doing. Bill pushed primary PCI. Eric Topol was in competition for patients because he was doing lytic therapy. We were doing both. I got to be in between both of them and understand what was going on the cutting edge in both. And we had a number of publications that gave our cath lab international status. One of the interesting things we did was, because this was the first genetic drug available, community hospitals were afraid to use it. So we started out by sending the helicopter team out, a new idea, to the community hospital, bringing the patient back to our hospital and doing the lytic therapy and then the rescue angioplasty. Then we sent a nurse out on the helicopter to deliver the venous therapy and bring the patient back to our cath lab. And then finally, people got comfortable getting it in the community hospital, and then PCI centers increased. At 1 month, I think we had 40 transfers for acute STEMI call, which is unbelievable. But we were doing a mass unit with people in the hall waiting to come get primary PCI because we were the only ones offering it, and we did a good job of selling it, and it worked. I mean, really remarkable. You see the EKG get better, you see the chest pain go away, you see the blood pressure come up. I mean, it was simple physiology, but stunning clinical advance. Another guy to recognize is Doug Weaver, who followed Sid Goldstein at Henry Ford. He started out in Washington, where that first community regional research group was doing so much good work on CPR in the field and ambulance triage. And he wrote an important article on the TIMI trial where reperfusion within 1 hour of symptom onset was associated with only a 1% mortality risk, emphasizing the time to treatment, which they really pushed hard on in the Seattle emergency medical system. And then he wrote an important meta-analysis that helped push everything over the top in 1997 when we were trying to figure out, is intravenous lytic therapy better or is primary PCI better? Because as I'll show you, it wasn't at all clear. Cindy Grimes was our fellow in 1988, along with Jim Blankenship, both who became presidents of SCI. And Bill and she did some really nice work at Henry Ford with the PAMI group, and she wrote the second important meta-analysis in the Lancet following Doug's meta-analysis of 10 or 12 studies, which in 2003 solidified the role of primary PCI as the first choice for reperfusion if you could get it. And this was a big argument. We've argued for years. This is US data from the NERMI registries along the timeline. The trouble with PCI is, again, we didn't have stents. We didn't know how good our equipment was. We were trying to figure out how far we could push it. We didn't know the right antiplatelet, anticoagulant therapy. The patient's IV lytic therapy actually did better until about 2001 or 2002, where clopidogrel was proven to be excellent with aspirin as dual antiplatelet therapy, so we could cut back from all the bleeding complications we were getting with anticoagulation, and where stents started to be available clinically. The first stent came out in 1994, but we didn't use bare metal stents in acute MIs because we thought it was a thrombotic nidus. And it wasn't until 10 years later that we started stenting acute MIs with bare metal stents. Then we had drug-eluting stents in 2003. But even then, you can see the great reduction in mortality, but equivalent mortality rates. The French had a really nice registry for about 20 years. On this slide, you can see if you got no reperfusion, you had, again, that 15 to 20% mortality at the end of a year. In-hospital lytic therapy and primary PCI, again, in 2000 was about equivalent. What really worked the best was pre-hospital lytic therapy. And that, again, is this time to treatment concept. If you open up the artery early, you save muscle, the patients live. And this is another slide showing the limits of the different strategies. TPA had a little bit worse endpoint freedom when we did that study. Angiobitis was a little bit better, but the problem, again, is reflected in the right picture where you have reocclusion high with lytic therapy, not as bad with PCI because you get away with the obstructing stenosis, but best with stent therapy. That really is what changed things and made PCI dramatically important. But we still have this time to treatment thing, which people have argued about forever. This is the Reimer and Jennings experiment showing that longer times of reocclusion gave you a bigger infarct size starting from the endocardium and coming to the epicardium. And this is the challenge we fought for, 15, 20, I mean, almost 40 years now. We've been doing, 40 years, over 40 years, we've been doing reperfusion therapy in the cath lab. And you see this wave front of necrosis coming. And the idea is if you can get them in the first hour or two, you save the most muscle. There's still some benefit after 5-6 hours, but it goes down, and perhaps it's due to wall motion salvage and electrical stability. But the time to treatment thing, it's an emergency. You got to go hard, even though it's inconvenient. You might want to stay in bed. Here's another registry report of door to balloon times. The line on the top showed we did better with our hospital systems of care. The bars show that mortality did go down. Those are associated, maybe not necessarily cause and effect. But we're making major progress over 15 years with a terrible disease that had no treatment before 1980 or so. My friend Hitender Gurm and Dan Manise had a really impressive publication in the New England Journal that resonated with interventional cardiologists who were tired of being hammered about trying to save 5 minutes in time to treatment at an individual level when the treatment was all, the benefit is at a population level. They showed in this NCDR registry that door to balloon times went down from 205 to 209. But there was no difference in mortality, suggesting maybe you didn't have to go as fast. But the statistical error in this is they took one average mortality rate for the whole year, which misses the subtleties, which my friend Brahmaji, I mean, Hitender had an office on one side of mine, Brahmaji had the office on the other side. He and Harlan Kumholtz and their people went back and looked at exactly the same data, divided it up into deciles and divided it by year. You can see there still is this relationship between door to balloon time that you lose if you just take an average mortality rate. And that's because we got more comfortable taking sicker patients to the cath lab. They were more severe, and we were getting the best benefit in the sickest patients. So I think everyone still has to agree that time to muscle is important. We saw that recently in an article at the ACC where they tried to put a Impella device in and wait before they reperfused the patient. It didn't work. The trouble is, in the great state of Michigan, 10 million people almost, a lot of people can't get to the cath lab within 90 minutes. Last time I heard, and I haven't checked for several years, we had about 45 primary PCIs, some with no on-site surgery. But if you get above Mount Pleasant, you know, only Traverse City, Petoskey, and Marquette have PCI centers. So lytic therapy still has a role to play, and some of these more rural places have this combination strategy where you give the lytic therapy, take them to the cath lab as fast as you can, but you don't wait 6 or 7 or 8 hours to get to the cath lab because by then you have a transmural infarction. Let me finish with a couple of words on cardiogenic shock. Tom Killip was chief of medicine at Henry Ford before, or chief of cardiology. Give me a thumbs up. Chief of medicine, period. Then he went down to Galveston and was dean of the medical school. Wrote a classic article from Cornell for the first 250 patients that were admitted to the new Cornell coronary care unit with a remarkable clinical result of this progression of mortality risk as heart failure got more acutely aware, that was reproducible in everybody's lab, CCU and hospital for years afterwards, with heart failure being worse than no heart failure, pulmonary edema being worse than heart failure, and cardiogenic shock, which you described those days as pulmonary congestion and hypotension, not a lactate that's 1/10 of a point above normal. That was real cardiogenic shock, not pre-shock. And then Forrester again wrote this hemodynamic profile article that helped promote measuring intracardiac pressures in the CCU with the same concept that the higher the congestion, the lower the output, the worse people did. So I actually, with a fellow, authored the first paper showing that PCI improves survival in cardiogenic shock. Not great methodology, but we had 24 patients with about a 50% mortality, and we went backwards and looked at patients with conventional therapy, 80% mortality. And I would argue it hasn't changed a whit since then. PCI is the only intervention that's been shown to reduce mortality from cardiogenic shock. Judy Hockman did the same thing in a randomized trial that cost millions of bucks, but the same concept. You can save 1 or 2 people out of 10 by going to the cath lab. it's tough to have people die on you, but it saves a couple people. And there's been a lot of interest on the Danger trial, on the Impella support device, changing mortality. But if you read it carefully, they were very clever. They omitted people with RV shock. They omitted people with cardiac arrest. Very carefully picked out a population of LV dysfunction that might be beneficial, but it took them 10 years to enroll their population. So it's not clear how applicable this is to general practice. And the Blue Cross Blue Shield guys have suggested that this is helpful in a small group of patients. But if it fits, it's great. But it's not clear that support devices really change outcome in shock. It's really early reperfusion therapy. So slide for me, I trained 101 people in interventional cardiology. I trained over 250 in diagnostic angiography. I got to work with Topol and O'Neill and the early international multi-center trials on reperfusion therapy. Met a lot of people that really wrote the history of this. And I got to lecture around the state and the country and around the world on reperfusion therapy and coronary artery disease. But my legacy is probably going to be my contributions to the guidelines committees and the consensus documents, which have legitimized and standardized this treatment, working as jury and judge. I got to be on the cath lab standard consensus document and the COCATS training in cardiac cath, and then served on the ABIM interventional cardiology test community. So there's some people around with certificates that have aged out that has my name on it, perhaps. The most fun was being on the STEMI guidelines committee with Elliot Antman and Paul Armstrong and Judy Hockman and Harlan Krumholtz and some other really smart guys with a couple updates. I got to chair the consensus document on carotid stenting, which broke down the walls we had with interventional radiology and with vascular surgery and led to the more recent guideline, which is more collaborative. It's really TAVR that broke down these societal barriers to working together. And then I was co-chair of the PCI guideline in 11 and a couple focused updates. And then I finished off my career working on the current coronary revascularization guideline, which is PCI and CABG put together. So I learned a tremendous amount over 20 years being around a table with people who are always smarter than I was, but it was really quite an extraordinary experience. So we spend an increasing amount of time talking about chronic coronary syndromes, fancy new revascularization techniques, CABG versus PCI still, great interest in intravascular imaging and flow measurements and complex coronary interventions. But remember, PCI and CABG don't change mortality in patients with stable coronary disease. We've got all kinds of great medical therapies that do primary and secondary prevention and give these people long survival times. It's really acute myocardial infarction that kills people. It's a damn coronary thrombosis. So the goal has to be to save lives with patients with coronary disease. We're unfortunate enough to have a myocardial infarction to achieve early, complete, and sustained infarct artery patency. I don't care if it's fibrinolytic therapy or catheter-based reperfusion. They all need to get a heart cath as quickly as possible. But whatever you have available, because the time to treatment is so important, you give it. And now we have really overwhelming data that after the acute treatment, even sometimes during it, but before a couple of weeks past, complete revascularization further improves prognosis in these patients. So PCI wins, revascularization wins, but lytic therapy is not gone in some of the rural areas of the world. We've gotten much better on antiplatelet and anticoagulant therapy, which has made the PCI procedure work so well. The challenges are time to treatment, hospital resources where you live, whether you have an ice storm in northern Michigan. So you have to have really both available. But while people focus on chronic coronary disease now and lose track of the fatigue of time to treatment and STEMI systems of care, you really need to re-engage in pre-hospital and hospital systems of care and give these patients the best chance possible, because the recent studies show no advantage of PCI or CABG in patients with ischemic cardiomyopathy. best treatment for ischemic cardiomyopathy is to prevent it with early reperfusion and elective revascularization in patients who qualify for it. So there you go. Thank you for letting me do this again. I hope it was better the second time than the first time. Back to our moderator.
Eric, that was amazing. Again, I think it's something that we can hear over and over. Just an amazing tour of the history of reperfusion therapy and the contribution really that the state of Michigan and has had towards this therapy. So we have a few minutes actually. If you'd like to place some questions in the chat, I can go ahead and try to moderate those. So if anybody has a question, would like to ask Dr. Bates, we can go ahead and please place those in the chat. Let's take a look here. Eric, I don't know if you see this from Lucas Rich, one of our fellows, used to be one of your residents in the chat there. History and physical of the University of Michigan means something.
Yeah, okay, I found it. Well, good. I hope you respect your training and go out and do better than we did. But there are, again, a number of people who have made important contributions, and I'm not mentioning all the people that enrolled patients in these trials. And there are a number of, all the PCI centers are really good now, partly due to the registry and sharing best practice. But interventional cardiology is really good in this state from continuing efforts and historical efforts. Thank you, Lucas.
All right. I don't see any other further questions here. Well,
okay. Are you going to archive this someplace?
And we're going to have this recorded, by the way, for anybody who wants to look, listen to this again. This will be on our website as well on the YouTube. You also do get CME credit for this wonderful presentation. Dr. Bates just did as well. So please make sure to claim that. Thank you again, Dr. Bates, for all your contribution through the years to this amazing field. And we're honored to have you amongst us and look forward to your next talk. So thanks again for your time tonight, everybody, and look forward to seeing you soon.